Sixth nerve palsy is defined as damage to the abducens nerve that leads to paralysis or paresis of the lateral rectus muscle, which is responsible for abduction or moving the eye away from the nose. This causes the affected eye to turn inwards as the action of the medial rectus is now unopposed. SNP patients will thus have esotropia of the affected eye. Their strabismus is incomitant as the deviation will be greatest when looking towards the affected side. It will also be greater in the distance compared to near. This is because when looking away from the affected side, the affected eye is already adducted for that gaze, but when looking towards the affected side, the affected eye is unable to abduct as it should for that gaze. On near viewing, the eyes would normally converge, and since the unaffected eye is able to converge while the affected eye is already turned inwards, there is a smaller deviation compared to distance where both eyes should be straight. Because of the strabismus, patients will often experience horizontal diplopia, which they may try to overcome by turning their head towards the affected side so that the ESO deviation is minimized.
Effective history taking and appropriate testing workup is essential for accurate diagnosis. Identifying risk factors is crucial in establishing etiology and prognosis, as SNP can be serious or self-limiting. Full visual acuity testing, ocular alignment testing, slit-lamp biomicroscopy, and fundoscopy must all be conducted. Patients with suspected SNP require full motility testing to reveal limited abduction of the affected eye in cardinal gaze directions. To determine strabismus and differentiate between complete and incomplete SNP, unilateral, alternating, and prism alternating cover tests must be performed at distance and need to establish the manifest deviation. Greater deviation is expected at distance due to convergence of the contralateral eye at near. Etiologies of acquired SNP include trauma, acute vasculopathy, neoplastic SNP, inflammation, infection, elevated ICP, and benign isolated SNP in cases of severe sinusitis. Duane syndrome must be differentiated as it can cause congenital abduction deficits. Acute SNP in children must be immediately referred to the local hospital, and adult patients with acute SNP must follow diagnostic procedures within the week. The following should be performed, and an MRI is required to rule out or confirm a neoplastic etiology.
Management should be compensating prisms or botulinum toxin injections for diplopia and head tilt prevention. Acute SNP patients with injection into ipsilateral eye can reach a recovery of under 10 prism diopter deviation and have progression in motor rehabilitation, reading, binocular accommodation, and near-point convergence. Adverse effects include transient ptosis or vertical deviations. Fresnel prisms can be put on spectacles to fix eye misalignment and reduce diplopia symptoms. Initial deviation less than 20 prism diopters connote SNP may still be in progression. As such, patients should be followed for progression. SNP is chronic after 6 months of lasting signs and symptoms of diplopia, head tilt, and esotropia. Then surgical methods are considered based on lateral rectus residual functionality and deviation size. Popular surgical procedures are shown below. Patients can have difficulties adducting and may develop slight vertical deviations after some surgical methods, and completely paralyzed eyes had less motility improvement after operation. Full recoveries connote normal ocular rotation and full binocular vision status. Stable recovery indicates binocular vision with minor adduction defects or asymptomatic vertical deviations. Non-recovery is considered when a patient has persisting esotropia and diplopia uncontrollable by vaginal divergence.
Created using Palsy.